Huh. Can you fix that to where you? You know what? Let me grab our handouts. Yeah.
Okay. So let's. I can. Yeah, it's not. We're not. Just make sure we got that.
That's backwards.
Okay, got it. Okay, good to go.
All right. Okay.
Okay, you have it rolling? Are we?
We're ready.
I guess we're recording. All right. Hi, everybody. My name's Philip Keiser. Can you see me on the webcam, or do all you see is the slides?
Well, actually, I can see you and the slides. Yes, sir.
Okay, fine. Let's just get the webcam on then, and then
Okay.
what I'm going to be staring at the screen just like you are, and
okay.
At least you can kind of see me as well, which sometimes adds a little bit of dual intake of info and can help a little bit. So what we're going to do today is we're going to talk about what I call antiretroviral therapy of HIV infection. But this basically goes through a lot of the issues that we have faced with the drugs and ends up talking about what the current recommendations are and what you should be using. So with that in mind, the first way we start is we start with the HIV life cycle. So this is a cartoon of a CD4 cell count. So the light blue is the cell, and then the gray is the nucleus, and the green is the DNA. Now, what happens, HIV is represented by this star here, comes and binds to the CD4 molecule, and then it fuses with the cell membrane. And after it fuses with the cell membrane, it injects its genetic material into the cytoplasm of the cell. And that is in the form of RNA. Now, when Watson and Crick first proposed their mechanism of DNA synthesis, what they suggested was that not only could you go from DNA encoding genetic material to RNA to proteins, but that could work anyway, from RNA encoding to protein encoding. And it wasn't until the 1970s that David Baltimore found that discovered retroviruses, and these are viruses that encode their genetic material in the form of a single strand of RNA, of which HIV is one. So it injects that RNA into the cytoplasm, and then, oh, I made a boo-boo.
That's all right. We also, Dr. Keiser, I think Jennifer was gracious and gave us these slides, so we're also able to look along here with our handout. So.
Yeah. Okay, there we are. Okay, so I have to be careful where I put the arrow when I'm not advancing the slide, because otherwise I'll get myself into trouble. All right, so here we have the RNA, and then what happens is an HIV-encoded DNA polymerase, which we call reverse transcriptase, then converts that RNA into a single strand of DNA, which then goes back and makes a double strand of DNA. And then that gets taken into the cell and into the nucleus of the cell, and it gets incorporated by an HIV integrase into the cell's DNA. Now, when that happens, that cell's permanently infected, and there's nothing that we can do to get that out at this point. And that's why HIV is an incurable disease at this point, because we don't know how to get rid of the DNA once it's been incorporated into the person's DNA. After that happens, HIV takes over the cellular machinery, and then it makes more RNA, and it also, from that RNA, it makes RNA that's used to encode the genetic material, but it also makes proteins. And it makes these proteins as a single long strand of a protoprotein, which is cut up in little pieces by an HIV-encoded protease, okay? And that's where the protease inhibitors work. They block at this step. Then takes these parts and incorporates them together and makes a new virus. That virus then goes out, which then can infect other cells. Now, the key is, though, is that when HIV infects a cell, it doesn't just have one virus in, one virus out. It's one virus in and hundreds of thousands of viruses out per cell. And when that happens, it disrupts the cell membrane and it destroys the cell. Okay, and so that's how we lose CD4 cells. One of the other issues with HIV is that it cannot proofread its activity. So here's a strand of RNA, and you can see, as you remember, that for every building blocks of DNA, it's adenine, guanine, thymine, and then cytosine, or for its RNA, it's uracil, so it's a single building block. And what happens is that every time you have a G, then the reverse transcriptase puts in a C. Every time you have an A, you put a T. Every time you have a U, you put a G there, okay? But this is what HIV does, okay? This is the way it's supposed to work, all right? So you have the complementary sequence on the other side, but what actually happens with HIV is it makes mistakes. So you see right here, this is a T, there should be an A there. And human DNA polymerases, when they make that mistake, they go, uh-oh, made a mistake, and go back, cuts it out, and then puts the right thing there. But here, you have a mutation that's occurred, and that has some really important implications for us, because what happens is mutations accumulate, and as mutations accumulate, the virus changes, and as the virus changes, it can become less responsive to therapy. So HIV is a dynamic process, and I think that's a very important point to keep in mind. As we watch our patients, what we see is that over time, their CD4 count just slowly declines, slowly goes down, slowly goes down. But what really happens is that you have HIV in infected cells, and then that makes HIV in the bloodstream, which is circulating in the bloodstream. It then infects other cells, which then become infected, which then make more cells. Now, some of these cells die. Some of these cells become latently infected. That is, that they have HIV in them. The HIV isn't replicating, but it still stays there. And so what we have over time is this circular process going on, where every time the body realizes that there's cells that are being destroyed or infected with HIV, it makes new cells. It makes more CD4 cells, which then become infected, which then generate more CD4 cells, which then become infected, and it's basically like a fire. It just keeps building and building and building. And what happens is over time, the individual can't keep up. And so what we see as a slow decrease in the number of CD4 cells that a patient has actually turns into a very rapidly ongoing process that allows for a lot of bad things to happen. So what happens is that we have these mutations in the virus, and so it's not like we have a single clone of a virus. We have what we call viral swarms, all right? And in these viral swarms, when you have this mutation occurs, some of these viruses actually get so many mutations that they can no longer replicate. We call them dead-end viruses. And there was a time in the 90s that some people were trying to force the virus to become all dead-end virus, thinking that they would cure HIV that way. It didn't work. Most of it is what we call wild-type virus, which is just the virus that you would find around anywhere. And then some of these virions are resistant, and they're inherently resistant. And so what happens is if you give someone a drug and some of these viruses are resistant to that drug, then these viruses start to grow more, and then you start developing a lack of responsiveness to the entire drugs. So this is a graphic of what happens when someone gets HIV. Over here we have a CD4 cell count, and remember, CD4 cells are the cells that provide the command and control to the immune system, and they tell the rest of the immune system what to do. So if you knock out this, then you really inhibit the body's ability to respond to infection. I don't know how many of you remember the first Gulf War. But the first thing the U.S. Air Force did to Saddam Hussein was they knocked out all of his radar, all of his communications, so he could not communicate with any of his troops or know what was going on. And that's basically what HIV does. So the red line is the amount of virus in someone's blood. So this is time 0, and this is the time course over a course of about 10 years. So at day 0, someone gets infected with HIV. You know, they had a really nice night out partying and you know, had sex with someone they didn't know, or they did some drugs, or something happened, all right, and they got infected with HIV. Initially, everything's fine, but over about 6 weeks, there comes this burst of viremia. The virus starts to replicate, and suddenly, boom, there's a ton of virus. When that happens, the amount of CD4 cells in the bloodstream drops very dramatically because it's chewing up CD4 cells like crazy. Now, one of the myths of HIV is that it evades the immune system. That's actually not what happens, is that it basically outruns the immune system. So initially, once you get this burst of viremia, the body's immune system kicks in and says, hey, we got a virus, and it starts to fight back. And then people start having symptoms. They have fevers, they have sore throats, they can have a rash, they have swollen tonsils and swollen lymph nodes everywhere, and it looks all the world like mononucleosis. And many times people will go to their doctor and their doctor will say, oh, you have a virus. And they're right? But they don't check for the virus, that is for HIV. And so it's important to be able to recognize this. This is the sort of thing that if you start looking for it, I promise you, you will find it. It's all around. And it just has to be where something like this is mono in a young person who may be at risk for HIV. Maybe we ought to test them. And you test them and often you'll find it's positive. So what happens is as the immune system starts kicking in, you start having these symptoms, and it drives the virus down into the reticular endothelial system. And then there's this equilibrium that develops. And that equilibrium is where between the virus and the immune system, it's able to keep the amount of viral replication in check at a specific level. And that level can vary for different people. And then over time, you see the CD4 count go down, right? Because you've got virus that's still replicating. And when the CD4 count hits about 350, they get pneumococcal pneumonia and herpes zoster. When it hits around 300, they're more susceptible to TB. When it hits 200, they're more susceptible to PCP and thrush and KS. When it gets to be 100, they can get toxoplasmosis and lymphoma and cryptococcus and candidal esophagitis. And then when it gets down to less than 50, they get MAC and CMV, and then they die. The average time from infection to death is about 12 years. Okay? Some people live a little bit longer, some people live less, but there's a wide variation in that. One of the key things is that helps us is that we do viral load testing. And some people ask, well, what does that mean, viral load testing? Well, what viral load testing is a way of allowing us to actually measure how much virus is in an individual's blood. So they take blood, they take plasma, and then the next step is to take that HIV RNA that you see gets injected into the cell, that gets isolated, and then that gets using reverse transcriptase, which is the HIV's own mechanism for converting it to DNA, that gets converted into DNA. And then using a PCR process, that gets amplified. So instead of where you have one copy, that can then get turned into literally thousands of copies. And now since it's thousands of copies, we can measure it and with that amplified DNA. And typically what we do is then it gets standardized to the amount of virus per ml, and anywhere less than 40 is considered undetectable. We'll get to that in a minute. And anything, then it goes up in a logarithmic fashion. Now, one of the things that's become very clear is that the amount of virus in people's blood predicts how fast they'll have disease. So this is a scale that we used to use, some years ago, and the limit of detection for the virus was about 400 copies per ml. Now we have technology that will take us down to about 40 copies, in some cases 20 copies per ml. We can never detect zero, all right? But what we found is that if you're under a certain level, your likelihood of progressing is very low. So they had all these patients, and they had varying levels of virus in their blood. And then they asked the question, how rapidly did people progress to AIDS? And the answer is, if you are at 400, that level of progression, then only 8% of those people progressed to AIDS. If it was about 20,000, 26%. If it was 75,000, 49%. And if it was 750,000, it was 62%. And so it became very clear how much virus you have in your blood predicts how rapidly you'll progress. Now, the very interesting thing is we've learned is that if you give people drugs and you take this guy here and you make his virus undetectable, his chance of progressing to HIV, to AIDS, is actually what it would be is if he had very little virus in their blood. And now that we have thresholds that go down to less than, tenfold less than this, if your virus is undetectable at, say, 40 copies, your chance of progression is pretty much zero, all right? And that's a very important thing because now the standard is to get the virus to an undetectable level in everybody, and that's how you prevent the disease from progressing. So we have a bunch of targets that we can use to treat HIV, and so, for example, we have entry inhibitors that prevent HIV from gaining entry into the cell, and things like cells entry, and then we have a bunch of HIV reverse transcriptase inhibitors. They fall into two categories: nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. So the nucleoside ones are drugs like AZT, 3TC, tenofovir, bacavir, drugs that you will be using. And in RTIs, the most common drug that we used here was a drug called efavirenz or Sestiva. In the past few years, we've moved away from that. It was a great drug back in 1999, and we saved a lot of people's lives with it. But in 2017, it doesn't hold up to some of the newer drugs. Okay. Then here at HIV integrase, and here we have 3 drugs that you can use. One's called Tivicay or dolutegravir, and then there's elvitegravir, which is marketed as either Stribild or Genvoya, and then there's raltegravir, which is a drug marketed by Merck. Generally, we use the first 2 drugs because they can be given as combo pills, and they're given once a day, and raltegravir isn't used as much. And then right here, the HIV protease inhibitors. And HIV protease inhibitors are drugs that you probably still will be using, although as we move into the future, I think less and less, because the integrase inhibitors really are better agents. They're easier to use, less toxicity, and less drug interactions. But it was the HIV protease inhibitors that really changed the game. In 1996, HIV protease inhibitors came out, and we found that by using an HIV protease inhibitor with 2 of these nucleoside inhibitors, that patients did better. We literally had patients on their deathbed who would get up and walk, and they'd come back in weeks later, and they'd say, "Hey, doc, I feel really good," and they'd be wearing their skinny clothes, and their clothes would be falling off of them, and then another month later they'd be filling out, and another month later they'd be kind of fat because they just hadn't been able to eat in so long, and they were feeling so much better. And so what we found is that if you put people on these potent combinations of drugs, that they will live a very long time. We honestly don't know what life expectancy is because we only had them for about 25 years. And we're still figuring it out. So, but we expect people to live a normal lifespan if getting on these medications. This is a list of the currently available HIV agents, okay? I want you to go home and memorize every single one of them. Tell me 3 side effects for each one. Actually, I'm kidding. There's no way you could do this because it's just, I know every one of these drugs because when I started off, we only had one. We had this AZT, okay? And now we have all of these agents, and we'll get to what the recommendations are, and I'll give you some advice on how you should really start approaching these agents. But you can see they fall into a variety of different classes, and but despite the fact that we have all these drugs today, the model is still the same as it was in 1996. You take 2 drugs from this list, plus either 1 drug from this list or this list, and that's how you treat people with HIV. Okay. Now, how well do these medications work? The answer is they work very well. So first of all, here we have another cartoon where we start HIV and then HIV therapy, and then you see the CD4 count drop. And then after the CD4 count drops, you get a big bump in the CD4 count. All right. Now these are memory CD4 cells. So what's a memory CD4 cell count? So if you ever had the flu, your body remembers that, and it stores that memory in a specific cell. If you got vaccinated for mumps, your body remembers that. Unless you only got one shot for mumps, after a while it forgets, and so then you need another shot. And after giving it two, it remembers that. And so these are things that you have been exposed to in the past. But that's only part of your immune system. Your immune system really consists of your ability to remember infections you've had in the past, plus respond to new infections. And so, again, over time, you have an increase in what are called the naive cells. And these are cells that when you see a new infection, they have some changes in their DNA, and then they become memory cells. And they help you not only fight off the current infection, but remember you've had it before. When you add these together, this is the trajectory of CD4 cell count increase. So you'll get somebody, a young guy, CD4 count, maybe is 20, and boom, it goes up to 200. And you go, wow, this is really great. And then you keep treating them, and it doesn't seem to be going up. What's going on? What's going on? But then after, maybe about a year and a half, you'll see it start creeping up again. And that's because it's the cumulative effect of this line plus this line. And ultimately, what many of our patients do is they'll have a CD4 count that runs 800-900, okay? And that's really where you want to be. Although the reality is sometimes patients barely get their CD4 count above 200, and getting above 200 is a good place because that's where people become at high risk for developing opportunistic infections. Okay, this is what happens over time when we treat people with HIV. So you see the data goes from 1985 up to 2006. So this is the number of people living with AIDS in the orange line. The blue line is the number of AIDS deaths, and the yellow line is the number of people with an AIDS diagnosis. So the first thing you notice is that from the 80s to the early 90s, the number of people getting AIDS increased, the number of deaths increased. And then right here, beginning of 1995, we see a big drop-off. And that's where HIV protease inhibitors were starting to be used. And by 1997, pretty much we had most of our patients on HIV protease inhibitors. So what happens to deaths? What happens to people living with AIDS? It increases, it increases. You would expect it to plateau because people would be dying and then new people would be becoming infected. But no. So we're having more and more people having AIDS because they're living longer. And what you see that drops off. But what's interesting is that it drops off, but it doesn't go down to zero. And I think this is a very disheartening thing because despite almost 20 years now, people still die from AIDS. Okay. And so we're not able to really keep people from dying from AIDS. If you follow it where this would have been, right, it's really great. But it helps keep people from dying. People still die from AIDS, so we still have to be vigilant. And we have to get people on therapy and try and keep them on therapy to keep that from happening. This is another study that CDC did where they looked at the chance of being alive based on the year you had your AIDS diagnosis. So in 1984, 1985, well, look at this. 90% of the people are dead, right? And then as time goes on, you see less and less people have died and more people are alive. And so here, we start using AZT, and then here we start using two drugs together. Here we get HIV protease inhibitors, and here we get more people on it. Now look, in the year 2000, to extend this line out here, what that says is that if you were diagnosed with AIDS in the year 2000, your chance of being alive 5 years later is 75%. That's pretty amazing. You think about what's your chance if you have class 4 congestive heart failure being alive 5 years later, or if you have small cell carcinoma of your lung, what's your chance of being alive 5 years later? The answer is it's pretty bad. And quite frankly, if I were told today that I had a choice of either having congestive heart failure or AIDS, I'd take AIDS. I don't know how I explain it to my wife, but I'd still take AIDS because I know that it's very likely that I will still be here 5 years later. So we've made a lot of progress, but we still have people who die from AIDS. It's also interesting that you save money by treating people. A lot of people never believe that. They kept asking, why are we spending so much money on these patients? And here's the answers. This is a study we did at Parkland. And we looked at what the monthly cost was based on the CD4 count that they came in at, and then and then where their CD4 count went. So if you came in with a CD4 count under 50 and you didn't take your meds and your CD4 count stayed under 50 in 2002, it cost Parkland Hospital about $3,500 a month, right? And then for every increase in these CD4 categories, you can see that your costs went down. And then you notice that as you get people with higher CD4 counts, that the CD4 count the costs go down even less. And so really the key is to get people's CD4 counts up so that you reduce the costs. And the people you spend the least amount on are the people that you diagnose with the highest CD4 count, i.e. their baseline's 350, and you keep their CD4 count up, right? So keeping people healthy saves money. And this is an important thing because a lot of time hospital administrators and other folks, they see what we're spending, they see what's going out each quarter. They don't see the cost avoidance. And so it's very important to keep in mind that when people ask you about that, that you just tell them, hey, we're saving you a ton of money. And if they want data for them, we can give you data. Okay, so, from this point, it's like everything's great. Everybody takes their HIV meds. People live longer. They don't have opportunistic infections. You end up paying less money. But it's not that easy. There's a lot of barriers to taking antiretroviral therapy. First of all, there's the barrier of the toxicities. And so we have what we call short-term toxicities, long-term things, and then problems with poor adherence and resistance. And so the short-term toxicities really can be quite manifold. Drugs like AZT give you nausea and vomiting, D14 DDI, which we don't use anymore, cause neuropathy. You could get pancreatitis. Abacavir, which we still use, can cause a hypersensitivity. So about 5% of white Americans and about 2.5% of black Americans have an allergy to abacavir. But it's not a typical drug allergy. It's a hypersensitivity where they develop fever, they develop a rash, and they develop nausea. And it usually occurs in about 7 to 10 days after starting it. If you keep treating them, they get worse. If you keep treating them, they get even worse. And if you keep treating them, they die. Okay? So the key is, as soon as someone has symptoms, is to stop it. Well, we can even do better than that. We now have a test called an HLA-B5701 test, and that if you're positive for that test, you have a 50% chance of having that toxicity. But if you're negative, your chance of having that toxicity is virtually zero. So we do that test in everybody that we want to put on abacavir-containing regimens. The non-nucleosides, they can give you rash, they can give you hepatitis. Efavirenz has what we call CNS toxicity, where people can feel like they are disconnected, that they're not able to concentrate. And so what we said was, okay, we'll take the drug at night. So people started taking the drug at night, and then they started having dreams. And some of the dreams were really bad dreams. I mean, imagine just being told you had AIDS and you're afraid that you're going to die, and people would dream that they died, saw themselves in a coffin. It would be very frightening to them. But other people would have funny dreams. I had one patient who dreamed that he was the star of his own pornographic movie. And he really liked the dreams. He was actually quite happy with them. But the problem was that this side effect goes away after about a month. And he came in and he wanted the dreams back. He was already sitting there pounding the table. He wanted them back. And I told him, well, that's probably not going to happen. And then he got, what if I stop the medicine for a while and start it again? And I went, no, don't do that. You'll develop resistance. So he left very unhappy. I never saw him again. I kind of wonder whether he's living somewhere, taking efavirenz, once a week and dreaming that he's a star of his own porno. Or now that the internet has come along and iPhones have come along, maybe he's really making his own porno. I don't know. But you get funny stories about it as well. So protease inhibitors, all of them cause diarrhea and GI discomfort. Okay, and then some of them, like atazanavir, can cause hyperbilirubinemia, and some of them can cause kidney stones. More importantly, what we see are disorders of fat metabolism, and this has been called lipodystrophy or lipoatrophy, but really what it's associated with is a redistribution of fat. You'll see this guy here, he has a buffalo hump, and then he has fat in his stomach, and then he has fat, he's lost his fat in his arms. Here you can see the buffalo hump, here you can see the wasting, the loss of fat in the face as well. It looks very characteristic. So can you still see me?
Yeah.
Or no?
Yeah.
Okay, here's what I want you to do. Take your hand and pull on the skin, just like this, okay? On the top of your skin. All right? Now, take your hand and feel your little bit of skin fat under your arm, okay? Someone with lipodystrophy, this part under the arm feels like this. It feels like what you feel in your hand. And so they really do lose a lot of fat. Here's somebody who has, they used to call it AZT bud. But basically, he's lost all the fat in his buttocks. Now, the problem with this is that it can be very disfiguring, and it identifies you immediately as someone who has HIV, who's taking antiretroviral medicine. I mean, and to this day, I'll be in Kroger's, and I'll turn around and I go, oh, there's a guy with AIDS behind me. Good, he's taking his medicine, you know. But it's called, you know, people don't like it. They call it Crick's belly because it was thought to be associated with Cricksaman. In the African American community here in Galveston, they call it the lick. You got that lick. And so people are very worried about looking like they have AIDS because that then outs them, and then they face a lot of discrimination because of it. One of the big problems we have with this is that we don't have a uniform case definition of it in order to determine whether people have lipodystrophy. So here's an example. So how many people know these guys?
I do.
All of them.
Not personally, but right. You know, so it's the Rolling Stones, right? You know, look at him. Look at Mick Jagger. Okay. Look at Keith Richards. You know. The only guy who really doesn't look like he has HIV lipodystrophy is the drummer. And if anybody should have HIV, these guys should. They have lived wild lives, drugs and sex and rock and roll, you know.
Right.
And they kind of got the look. Do they have HIV? I have no idea. But you know, just like Magic Johnson, they were famous enough at the time and wealthy enough at the time when these drugs came out that they could have gotten on them very early on. And so it's very easy to look at somebody and say, oh yeah, they've got HIV. But the problem is that you can have this look without having HIV. I'm going to prove it to you right now because I'm going to show you somebody who has the look who I know was not alive when HIV was around. Anybody recognize him?
Yeah.
Look, the sunken eyes, the hollow cheeks, the deep lines, you know. If they were around today, people would be whispering about him. And so because, you know, some people have this kind of body habitus, it's very, very hard to study, and we don't have a lot of good information. The one good thing I can say about it is that with the drugs that we're currently using, and the ones that are recommended by the DHSS panel, they're not associated with lipodystrophy. So if you can stay away from the older drugs, the chances of getting this is very unlikely. Nevertheless, you're going to have patients who know people who look that way, and they'll say, oh, I don't want to go on that drug because I don't want to look that way. And so what you're going to have to be able to do is be prepared and say, hey, you know, I get it, but these newer drugs that we're going to give you, they don't do that. It's going to be okay. Okay. So then the next issue comes about poor adherence and people not taking their medication. So in order to suppress the virus, which you see right down here, you need a certain amount of drug in your bloodstream. Now imagine you miss a dose, right? What's going to happen is that the levels are going to go back down, and then you take your dose again, and it comes up again. And you keep doing that, one of these viruses is going to get a mutation, and when that mutation occurs, there's not going to be enough drug to suppress it, okay? And that results in something that looks like this. So we saw this slide before, and here you have your wild-type virus, except now you've got them on a drug. But you got them on a drug that's not sufficient to completely suppress viral replication. So what happens? Suddenly, most of your virus now becomes resistant HIV because it's under the selective pressure. You have very little wild-type virus, and you do have that dead-end virus that's still there. And so this grows and grows, and then you continue to get CD4 count drops, and that's what we would call, a virologic failure. There is a clear relationship between taking medication and having a viral load undetectable. This study was done actually in the 90s using regimens that we don't use anymore. Like you have to take 3 times a day, maybe 5 pills 3 times a day, and people would have a lot of noise in the body. But if you took less than 50% of your drug, your viral load was, less than 50% of people had an undetectable viral load. If you took somewhere between 80 and 90%, 99%, you had a viral, 65% of the patients had an undetectable viral load, 100%, 65% of the patients had an undetectable viral load. So that 80% cutoff seems to be important. If this, like I said, this study was done back in the 90s. If you were to do that same study today, where we give people single tablet regimens, 1 pill that has all the drugs in them, where they only have to take 1 pill once a day, and where they have very few side effects, what you find is you have 90% of the people having undetectable viral loads. But once you start missing about 80% of them, or get less than 80% of your drugs, it starts to fall off. But imagine what kind of pressure that puts on people with HIV. So I have high cholesterol, right? What happens if I miss my atorvastatin, which I did today? Well, my cholesterol goes up a little bit, okay? But I can take my atorvastatin tomorrow, and everything's going to be fine. If I miss my HIV medicine, and I miss it a couple times, now suddenly the medication stops working. So what we do is we tell people, okay, here you are. You got to take this medicine. You got to take it every day. You can't miss it. It's going to make you feel sick, and it's going to make you look funny. And if you screw it up, you're going to die. All right? And that's a really hard thing to put on folks. But people still try because they don't want to die. There was a study that was done where they asked a bunch of doctors why patients don't take their medicine. And the doctors came up with, oh, well, they have hard lives, they're socioeconomically deprived, they have mental illness, they feel ill, they're depressed. And then they went out in the doctor's offices and asked the same doctor's patients, why don't you take their medicine? Number 1, I forgot, right? I was asleep, I was away from home. It's like my teenagers when they didn't do their homework. Why aren't you doing your homework? Oh, I forgot. But this is true. This is the way people are. We forget to do things. Pill taking is not a natural behavior. And so there really has to be a way to try and help people improve taking their medications. And let's go back. And one of the best ways to do it is using single tablet regimens, and I'll show you some of those when we get to the actual recommendations of what we should be doing. So one of the questions that has always come up with HIV medicine is, who should I be treating? Should I be treating the people that are really sick? Should I be treating the people that are intermittently sick? Should I treat people that feel fine, that have no problems? Well, there's problems with every one of those strategies. If you only treat the people that are really sick, well, then you let a whole bunch of other people CD4 count get low to the point where they get really sick. And if you treat people that are kind of intermediate, well, you can keep them from getting sick, but then they may be subject to toxicities, and even when they don't feel bad. And if you treat everybody, well, you're going to have a bunch of people who feel just fine. And we know with things like hypertension and high cholesterol that when you have a disease entity where people don't feel it and they feel fine, they tend not to take their medicine. So you're making resistance. So in a way to answer that question, there was a study called the NA Accord study. This is a very large database that includes, I would say, probably 50% of the HIV patients across America. And they looked at the time from 1996 to 2005 and asked the question is which was better, to treat people when their CD4 count was between 350 or 500 or greater than 500, and then look at their chance of death. And what happened was that if someone had a CD4 count of 500 and you waited till their CD4 count fell below 350, they had almost double the chance of dying than if you started treating them when their CD4 count was 500. Or if they started it at somewhere between 350 and 500 versus not starting until they dropped below 350, they were more than 1.5 times likely to die. Okay, and here's kind of the data in tabular form where you can see the various things. But just look at important deferral of antiretroviral therapy, 1.6 times more likely. Women, less likely. to get treated, okay, and more likely to die. Older age, you're more likely to associate it, but as if you were started at an older age. And your baseline CD4 count also had a figure. But here, deferral of antiretroviral therapy, when you include the RNA data and determine whether their RNA was detectable or not. Again, every way you look at it, it argues that it's important to start people early. So now the standard is that you should start antiretroviral therapy regardless of CD4 count, unless you have a reason not to. And that's the simplest way to say it. Now, what are some of those reasons not to? Well, you know, patients actively doing drugs and it's not going to adhere to their therapy. The patient has a lot of problems with mental illness, extremely unstable home life, and not going to be able to take their therapy. They don't have the funding for it, and you don't want to give them a copay card where they get their drug for a month and then everything falls off and they're not able to take their therapy. So in general, we try and get everybody on. But the nice thing about it is trying to get everybody on therapy. When you have a high CD4 count, you have time to work through a lot of those issues to get them to where they need to be. Now, when you're talking about people at the other end with a low CD4 count who's just been discharged from the hospital, you know, you kind of throw caution to the wind. You get them on drugs because if you don't, they're going to die, and they're going to die soon. Whereas with people with higher CD4 counts, you have the luxury of time, and it's probably worth it to take that time to figure out how to make sure that the conditions are going to be right, that they can start on their medicine and stay on their medicine. So there's this idea of a treatment cascade. And the treatment cascade asks the question of all the people that we're treating, how effective are we being? So, you know, in the United States in 2012, it turns out that 82% of the people who had HIV were probably diagnosed. So there's only about 20% or less than that in terms of the number of people who don't even know that they have HIV infection. And then we have the next question, linked to care. So there's people out there, but have they been linked to care? Are they been sent to a clinic? Well, 66% of them have. Okay? Okay, well, not so bad. But then look at this big drop, retained in care. A lot of people come to clinic, but they don't stay in clinic. And this is where case management becomes so important, because it's the case managers that really chase these people down and help them with the issues that keep them in care for a long period of time. And then it's only the ones that get retained in care that really gets prescribed antiretroviral therapy. So you can see most of the people retained in care get on antiretrovirals, and then of those, you know, about 75% of them have an undetectable viral load. And that's pretty good. If you can have 75% of your patients retained in care have an undetectable viral load, that's really good. But look at total effectiveness. In terms of the number of people in the United States who have HIV, who have an undetectable viral load, we're doing very badly. And most of the problems lie here in the linkage and the retention in care is where we really need to do it. So those are things that we need to be working on. And quite frankly, those are things that really are community-based. They have to be done within the community. You know, the U.S. government or the Texas State Department of Health, you know, can come up with all these programs, but we have to really be pushing to do that within our own communities to get better results. Okay, so one of the big things now that's come is actually simplification of antiretroviral drugs. So this used to be a regimen that we'd use all the time. It was Combivir and Nalfinavir. So Combivir had AZT and 3-TC. Nalfinavir is a protease inhibitor we don't use anymore, and you had to take 6 pills twice a day. We saved a lot of people's lives with this regimen, a lot. And it was one of my favorite regimens for a long period of time. But look, you got to take 6 pills, okay? Not only that, you see this blue pill? It's very hygroscopic, meaning that if you take a long time to swallow it, you know, some people just kind of go, boom, and go down. But if you're one of these people that has a hard time swallowing pills, well, your saliva gets soaked up by the pill, and the pill starts to grow in your mouth or in your esophagus. It's almost like a fizzy, not quite. But some people just can't take it. It also causes diarrhea in almost 100% of people. Some people, it was a little bit of diarrhea. Yeah, I have some loose stool. Some people, it was so bad that they couldn't take the medicine. So the next step was to get a once-a-day regimen. And this was our first once-a-day regimen. Tenofovir, 3-TC, and efavirenz versus Stevase. So now you could go to 3 pills once a day. Go, wow, this is great. Not only that, these two pills don't have a lot of side effects. This causes some kidney damage, but we monitor that. This one can kind of make people crazy, but sometimes they're crazy fun, and so that's okay. And again, we saved a lot of people's lives with this regimen. And then came this, and this is a drug called a triplet. So this had all of those same 3 drugs in a single pill where you could take it once a day. And that actually spawned the era of using single tablet regimens. So now we have probably 6 different single tablet regimens that can be used. And quite frankly, if you should be using single tablet regimens unless you can't. And there's lots of combinations of drugs out there that you can potentially use to try and meet a patient's particular need if they have toxicity or resistance, what have you, and should include a single tablet regimen because it makes things go much better. The other thing we found out is that if patients have a toxicity to a single drug as they're getting singly, when it gets put in a single tablet regimen and you give it to them, oftentimes those toxicities go away. And so, for example, with Combivir, which has AZT in it, people who took AZT said, "Oh, I'll never take AZT again. It almost killed me." And you say, "How about Combivir?" And they go, "Okay, fine, I can take that." And they don't have any problems with it. And there's some pharmacologic reasons for it, but there's also the perception reason for it. And that's one of the things that I can't overemphasize. If a patient thinks a drug isn't working or is causing him harm, he's not going to take it, even if he's totally off base. All right? So I don't argue with my patients when they tell me, "I can't take this drug because." I can't take this drug because the answer is, okay, fine. I even had one patient who came in, and he'd been off drugs for a while, and he said the drug gave him problems. I asked him what the drug was. He couldn't remember, but it was kind of an orange. And I said, "Was it this?" And he goes, "No, is that orange?" And I go, "Well, is it this one?" And then he goes, "No, is that orange?" And is that orange? "I can't do orange." He kept saying, "I can't do orange." And finally, I realized what he was saying was he couldn't take an orange pill. So finally I said, "So can you do blue?" "Oh, I can do blue, no problem." And so we found a nice blue pill for him, and he did extremely well, right? Totally, from our point of view, his rationale was nonsensical, right? It just made no sense. But somewhere along the line, he got a pill that was an orange color that made him feel bad, and so he wasn't going to take another orange pill. And so we had to find something that he would take. And again, it highlights the point that you have to work with the patients, and a lot of what we do is negotiating. We negotiate with them on things about taking their drugs. Okay, so what are the recommended regimens? And basically there's some protease inhibitor recommended regimens, and there's only one. It's tenofovir and emtricitabine plus darunavir and ritonavir. And then there's integrase based regimens. The first is abacavir, lamivudine, and dolutegravir. This is available as a single tablet regimen called Triumec. And then there is tenofovir, emtricitabine, and dolutegravir. And then there's tenofovir, which is called TAF. This is a new version of tenofovir, plus emtricitabine, plus dolutegravir, okay? And then there's an older version of that called Stribild, tenofovir, emtricitabine, dolutegravir, cobicistat, which is also available as a single tablet regimen. The 2 regimens that I would advise you studying up on, because you're going to use them the most, are this one: abacavir, lamivudine, dolutegravir, which is Tivicay, or tenofovir, TAF, emtricitabine, dolutegravir, and cobicistat, and that is called Genvoya. If you learn both of those regimens, you will be able to treat 80 to 90% of your patients with those drugs. And what you'll find about these drugs is that they are extremely well tolerated, they have minimal side effects, and they work extremely well. And patients' acceptance is really good. A couple caveats. Remember, abacavir has the hypersensitivity, so you have to test for hypersensitivity before you put patients on there. The caveat with TAF is that cobicistat, which is used as a way to increase the levels of dolutegravir, can increase triglycerides and cholesterol. So if a patient has a problem with cholesterol, this is probably a better drug. If a patient has the allergy, this is the better drug. But this is what I tell my fellows, this is what I tell everybody else. Start off simple. Start off learning some of the medications. Now, you're going to be getting transfer patients, so they're going to be on a wide variety of things, all right? And there are two ways you can approach it. Early on, as you're first starting, my recommendation is that if it ain't broke, don't fix it, right? You know, if they're taking like 30 pills with some drug that you've never heard of, but they're happy as can be, leave them alone, okay? But once you get a little more comfortable with them, then what I would suggest you do is look for opportunities to switch them to either this agent or this agent. And the reason being is that there's actually studies, and I think there may be one example of one of the studies in this deck, that shows that when you switch people, they do better, okay? And why do they do better? Because they have less side effects, it's easy to take, they take their drugs. If we make drugs easy to take, palatable, without side effects, people take them. And when we make it hard, it's harder for people to take them. Okay, now, so this just shows you some examples of why we use this drug. So we were using efavirenz for a long period of time, and this is a study comparing dolutegravir, which is the main ingredient in Tivicay, against efavirenz or Sestiva, which is the main ingredient in Atripla. So this is the portion of people that have an undetectable viral load. This is Atripla. This is dolutegravir. And look, it's better. More people have an undetectable viral load. They get there more quickly, okay? And when you look at CD4 count increases, people have a better CD4 count increase with dolutegravir. One of the things with dolutegravir you have to be aware of is that this drug inhibits the excretion of creatinine, all right? So if you put a patient on the drug and they have like a 0.5 to 0.8 increase in their creatinine within the first couple of weeks, you don't have to worry that they're going into renal failure. It's just a byproduct of the drug. It does not decrease GFR. They do just fine. On the other hand, if you put them on a drug and they slowly start increasing over time, well, then you have to really consider whether that's real renal toxicity. And in those cases, we would actually measure their creatinine clearance and see what's going on with that. But if you see an initial bump, within the first week or two, you can see it's actually occurred within 2 weeks, and then it's stable over time. It's nothing to worry about. I don't want to skip over that. Let's go back. Okay. So when you look at side effects of dolutegravir compared to efavirenz, the main side effect is, where are we? I'm missing it. It's basically headache. 2% of the people have headache. 2% of the people have sleep disorders. They just can't sleep. When you look at efavirenz, you can see that when you have neuropsychiatric disorders, it's 15%. Skin and soft tissue, it's 13% compared to 0. That's because efavirenz gets you a rash. GI disorders, a little bit with efavirenz, not much. And then this is just sort of an incident infections and other things that occurred. Okay, here we go, headache. About 3% of the people in this study, and then sleep problems as well. So it's a very, very well tolerated drug. Very few people have to come off of it. I've literally placed hundreds of patients on this drug. I've had 2 people complain of headache, one guy and sleep disorder. One guy was having all this problem with headache and sleep disorder, but then his boyfriend told us he's doing lots of crack. And so in working him up, we said, okay, we want to trust you do some drug testing as well. And he agreed. And sure enough, he came back positive for crack and crystal meth. And went back and said, look, you're doing this stuff, you're doing too much, and this is what's probably causing your headache. And he kind of said, yeah, you're probably right. Second one is a stand-up guy who used to be the head of IT for Methodist Hospital System, comes in and complains, I'm taking this drug for 2 weeks, I can't sleep, and I have a headache. It's got nothing else going on. We stop the drug, it goes away. So you will see it, but again, it's not very common. Okay, so how should you start people on therapy? All right, and basically, this is what's suggested that you do, is that you start people on therapy with to get a CD4 count, and then check that every 3 to 6 months. And then, for the most part, this is for some people who still want to wait until their CD4 count is less than 300. But basically, you want to start therapy unless you have a reason not to. So we get the CD4 count. We want to see what it's going. You're going to see all sorts of stuff like this. But really, if you look at the latest treatment guidelines, which just came out about a couple months ago. It's, start them regardless of CD4 count, okay? And I think that's kind of about it. So baseline, what we do is we check a CD4 count, we check a viral load, we get a resistance test to make sure that they're not resistant, we get an HLA-B5701, we get a CBC, we get a basic metabolic panel, making sure that their kidneys are okay, we get LFTs, and we get cholesterol, all right? And if you have all that, then you bring them back their next visit, and then you can make a treatment decision. And you can start doing, and again, I would suggest starting off with either Triamec or Genvoya. And most of your patients will fall into those categories. If you have problems where initially you're not sure what to do, give us a call, and we can give you some advice on how to approach it. One of the other things that's going to happen is that once the word gets out that you're treating HIV patients, expect the drug reps to come up and start telling you why you should use their drugs. And my advice is you should at least get lunch out of it for the privilege of listening to the spiel. But my opinion, different hospitals have different policies, but also different people have different feelings about pharmaceutical reps. My feeling is that nobody tells me the holes in the other guy's drugs like his competitor, And so I listen to the good parts, I listen to the bad parts, and then I make my decision. So I talk to everybody, and you can be guaranteed that the competitor is going to tell you that his drug's a little bit better than it really is, and that the other guy's drug's a lot worse than it really is. And so as long as you kind of keep that, and then you synthesize it and look at their literature, I think you'll learn a lot. But you can learn a lot from those guys as well. So I would encourage you to talk to them. So with that, I'll stop. I'll take any questions if anybody's got any.
All right.
So there's no more genotyping with new HIV patients?
We do genotyping at baseline. Yep.
Baseline.
At baseline, okay.
So you do genotyping at baseline. Now, if someone fails, all right, what is failure? So failure is that they come in and their viral load's detectable. And then you say, your viral load's detectable. How have you been doing taking your medicine? Oh, doc, I haven't missed a single pill. I'm doing really great. Blah, 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 blah. I never accuse my patients of lying. I say, well, I'm really worried about this. So here's what we're going to do. I want you to, the next month, just be really crazy about taking your medicine. Make sure you take it on time. Don't miss any, And they all nod like, oh, no, I never do that, right? And you go, that's fine, right? And then come back in, we'll check it again. So you come back in, you check it again, and half the time it's undetectable again, okay? So, they have been missing it, and then people are afraid to admit it. There's actually studies done about who are patients most likely to tell that they're not taking their medicine. And the answer is that they're most likely to tell somebody sitting next to them in the waiting room, followed by the nurse that's checking them in. Okay, and so that's why as you get to know people, it's really good for the nurses to develop relationships, because they'll confess stuff to you that they're not willing to confess to their care provider, And it doesn't matter whether you're a PA or a nurse practitioner. If you're the care provider, they see you as the doctor and the authority figure, and they're not going to be as open with you as they will with other people. And so it just takes time to develop that. Now, if they come back in and they're still detectable, then the next thing to do is to get a genotype, all right, and find out what they're resistant to. And so once you find out what they're resistant to, and that test usually can take anywhere from a week to a couple weeks to get back, you bring them back in, and then I ask them about what problems they have taking their other medications, because now I've got to make a decision. I've got to put them on something different, and that something different has to be something that they're going to be willing to take, and that something different has to be susceptible or it has to be active against their virus as determined by their genotype. And so that that's kind of nuanced, and I could lecture you on that for hours, and I promise you, you're not going to get it until you actually start doing it. It's one of those things you learn by doing it. And I also promise you, you're going to make mistakes. We make mistakes every day. And, and when you make the mistakes and it doesn't work, you go, okay, now what? And we do this every day. So, so don't be discouraged if you find yourself in an area where you're not sure what you're doing. That's, that's going to happen. And then again, if you have those things, call us up and we'll give you, we'll give you free advice. Take it for what it's worth. You're not paying for it. And at the end of the day, it's up to you. So what you want to do, but we'd be happy to help you out with those decisions. Okay, other questions?
I have just one more. From on the slide that talked about women being less adherent to care or likely to accept care later. Is there anything that you're implementing in your practice to get those women more adherent to care that we could utilize here?
Right. So there's nothing specific that we do for women, but I'll tell you what seems to work or work better. So you have to understand why women don't take their medicine. They don't come in and they don't take their medicine because they're the caregivers. They're taking care of everybody else in the family, and they put everybody else's care first. Okay, and that's a huge barrier. So encouraging them to you care for other people unless you take care of yourself. Trying to get that process is an important one. Finding barriers to care. And the barriers to care are transportation, child care, work, and working around those things. And you have to be creative. I think having women case managers helps a lot with that because, again, women are much more willing to talk to other women about some of the barriers they face than they are to men, particularly if the men are seen as authority figures. Sometimes women can be in abusive situations. Sometimes there's issues with drugs. Again, have to help people deal with those situations, and particularly where the abusive situation can be very, very difficult unless she's willing to say something about it, and a lot of women don't. The nice thing about Texas is that if all you got to do is, if a woman's being abused, all you got to do is call the cops and say the woman's being abused, and that guy's going to jail. And so you can get people out of those situations quickly if they're willing to pull the trigger. But there's just so much that goes into that, and then they potentially put themselves at risk. If it's his house they're living in, he doesn't stay locked up. And all these different things come into it. Another thing that's been helpful is, in some places, is having women's support groups. So get the women together, particularly if you can have some older women who have HIV, who have been in therapy for a while, and have them meet with the other women and talk things through. That way they see a role model of somebody who can, oh, they can do that, I can do it too, or there's someone who I can talk to and who can help me out with those things. So those are the things we face. There's no magic formula to it. It just takes a lot of time, a lot of effort. Any other questions?
That's it for today.
We think that's it, Dr. Keiser.
Okay, so not next week, but at some point we're going to have Dr. Patel in this series come talk to you, and she's going to do a whole thing on primary care. So it's about how you do the initial evaluation, which I just kind of touched on briefly. How you do the initial evaluation, what things you need to look for, how you follow it up, and we want to get as many different people in as we can. So that you have a good flavor of it. If you just hear me thrown on, you're going to get my approach, and which I hope has some strengths, but I know has some weaknesses as well. And so it's good to see how different people do it, and that way you can start to develop your own approach toward it.
Great.
Okay, all right. So same time next week.
Yes, thank you for your time.
Okay, all right. Talk to you later.
All right, bye-bye. All right. Oh, yes, please. Thank you.